The views expressed in this podcast do not reflect those of our training institutions or the APA. The information discussed is intended for educational purposes only and should not be used for diagnosis or treatment. Enjoy! Hello, this is Barrington Hwang. I'm one of the media editors for the American Journal of Psychiatry Residence Journal podcast. I'm here today with Dr. Eric Zabriskie.
Hey, this is Eric.
Dr. Jose Alberto Arriola Vigo.
Hello, I am Beto Ariela Vigo.
Currently, Eric and I are at Vanderbilt University Medical Center in Nashville, Tennessee. Previously, Dr. Ariela Vigo was an assistant professor of psychiatry at Vanderbilt. Now he is working and living in Houston. Today, we will be talking about his work with Peru. He wrote the chapter for Peru in the textbook Innovations in Global Mental Health and has been involved with the Peruvian government on mental health care reform.
So, Dr. Ariela Vigo, why don't you just first introduce yourself, give us a little bit of your background and some of the work that you've done.
Well, I'm originally from Peru. I went to medical school in Peru. I grew up over there. After I finished medical school over there in 2010, I stayed there for a year and a half to work as a primary care physician in an underserved area before moving to the U.S. for my residency training. I came to the U.S. specifically to Vanderbilt for psychiatry residency, and then I did a fellowship in consultation psychiatry. In the meantime, I'm also pursued Master of Public Health and MPH degree with emphasis on global health. And that's how my interest in global mental health grew over time. And then after I finished my training, I stayed on faculty at Vanderbilt. My clinical interests are focused on taking care of minorities, specifically Hispanics, African American, and people with limited resources. From the research standpoint, I'm interested on community mental health initiatives, residency and medical student education, specifically with emphasis on global mental health.
What drew you into psychiatry as a field? And secondarily, what is so captivating or important to you about both minority mental health and global mental health?
I was always interested in psychiatry because of family reasons. I have mental health providers in my family, but I was also interested on internal medicine and cardiology and how they play a role into quality of life on patients. But during my year as a primary care physician, I actually had exposure to treating a lot of patients with mental health conditions. In the place where I practiced as a primary care physician for that year, there was no psychiatrist available. Actually, the closest psychiatrist was 4 hours away, 4 to 4 hours and a half away from where I practiced. So basically, it was pretty much impossible for people to go and see a psychiatrist over there. It was even if I made the referrals, they were not going to get to see a psychiatrist. So basically, I started treating some of them, and that's when I got really motivated to treat these kind of patients, and I saw the change in their quality of life.
Thank you so much for giving us a little bit of insight on what you were thinking when you were thinking about specialties. Could you tell us a little bit more about the big picture idea of the mental health structure in Peru right now?
Sure. So we have a very disjointed and disconnected healthcare system, and that doesn't only apply to psychiatry or mental health care. That also applies to other specialties. Basically, in Peru, in summary, we have probably 4 different healthcare systems. One of the biggest entities or organizations that is in charge of healthcare in Peru is led by the Ministry of Health. Basically, they usually take care of about 60% of the population in Peru. Their services are mainly targeting people with limited resources. It has a lot of limitations because they also don't have a lot of resources, and the waiting times, to get care or to access to care is very long. The second major entity that takes care of people in Peru is something called Social Security. That's a partially subsidized system by the government. So basically, they take care of about 30% of the patients or the population in Peru. The services on this entity, on this healthcare system, are a little bit better than that is led by the Ministry of Health. but it also has a lot of limitations. And then we have a 10% of people in Peru that are taken care of by private clinics or private insurances or by the armed forces, similar to how the veteran system works here in the US. A lot of the initiatives that have been developed as part of mental health reform in Peru were mainly led by the Ministry of Health, meaning that those initiatives do not necessarily impact the care of people that are taken care of by these other healthcare systems, the Social Security, armed forces, or private insurance, or private clinics.
Thank you so much.
Can you talk a little bit about some of the work you've done studying the mental health centers in Peru, some of the mental health reform measures they've done there? If you can just describe what's going on there and some of the work you've done looking into what's going on there.
Yes. So the work that I've done in Peru is basically looking at the community mental health centers. Basically, just to have a little bit of background, in Peru probably around 2004, 2005, the government started to take several steps to try to change how mental health care is delivered over there. There were small changes that happened initially, from 2004 until 2012, and then from 2012 and on, there were more changes, more drastic and rapid changes happening. So this period of time that probably started around 2004 until now, there is something called mental health reform that has occurred in Peru. Basically, this reform focused on improving mental health care in Peru. And there were different steps that were taken by the government, by private institutions, with the ultimate goal to improve mental health care over there. The goal was to basically transition mental health care from the hospitals to the community. So people or the structure of the healthcare system doesn't rely on tertiary healthcare facilities only, and actually they rely on community mental health centers and primary care clinics to take care of patients with mental illness. Just to have also a little bit of understanding on how this looked like before, we need to think about where patients used to go to get mental health care. So basically, before mental health reform started, before 2012, most patients that needed mental health care had to go to psychiatric hospitals. 3 main psychiatric hospitals in the whole country, and basically they took care of most patients with mental health conditions over there. The problem with that is that these hospitals had collapsed already. They didn't have enough providers, enough services to take care of all patients with mental health conditions over there. The consequences were that people had really long waiting times to see a mental health provider. Some of them were not able to access mental health care at all. Some of them had to look for a private psychiatrist or private mental health provider in the community, and some of them couldn't afford to go to see a provider in the community either. That was one of the problems. The other problem was that since everything was focused or directed towards these 3 major psychiatric hospitals, most of the money that the government spent on mental health care was directed to 3 major psychiatric hospitals. Actually, 98% of the budget spent in mental health by the government was directed to these 3 major psychiatric hospitals, meaning that basically there was not any money to provide mental health care outside these 3 major psychiatric hospitals. The other potential problem before mental health reform started was that the money spent in mental health was not enough. They had 2 main goals. One was to try to spend more money on mental health care, and 2, to transition the mental health care to the community. Basically, what they proposed was to create community mental health care centers to organize and coordinate the care of patients with mental illness. They were supposed to be in the community. Patients would be able to access care through these centers, through these community mental health centers easily, and these centers would be able to coordinate care with primary care centers, with general hospitals, psychiatric hospitals. So we would avoid sending patients to the 3 major psychiatric hospitals in Peru that were already collapsed. On top of these community mental health centers, the community mental health care model proposed to also implement 4 other facilities. One was the psychosocial rehabilitation centers. Then they proposed to implement occupational rehabilitation centers with the ultimate goal to provide patients with, or to teach patients job skills, so they will be able to at some point find a job and start working again in the future. Then they proposed to create protected homes and protected residencies. Protected homes basically for patients with poor social support that basically needed a place to stay, similar to halfway houses here. And then protected residencies. The goal for these facilities was to basically provide housing support for patients with chronic mental illness that had debilitating or disabling sequelae from the mental illness. On top of that, they also proposed to improve and spend more money on general hospitals to also implement more inpatient psychiatric beds and partial hospitalization programs in general hospitals. So they try to decentralize mental health care and move the mental health care outside the psychiatric hospitals. Basically try to provide mental health care in the community.
So, you talked about a lot about the aims of these programs since 2004 and then later again, and what they were kind of supposed to do in decentralizing some of the care. What's your take on how it actually worked, some of the outcomes?
Yes, so that's a good question. There was certainly a significant change on the amount of resources spent on mental health care in Peru. By the end of 2018 or the beginning of 2019, there were already 104 community mental health centers implemented in Peru. There are at least 8 protected homes also in Peru. Services are growing over time, and we clearly have seen a change in the way that mental health care is delivered in Peru. I don't think we're yet at the place where we propose to be, but we are moving towards that. Actually, there were a couple of studies last year that showed, I think between 2015 and 2017, they looked at the number of visits for mental health care that were provided or that happened in the first 29 community mental health centers. And basically they saw that the number of visits done in these 29 community mental health centers were equivalent or were very similar to the number of visits that the 3 major psychiatric hospitals provided in the same amount of time, with probably much, much less amount of resources spent. And so that means that actually the mental health reform is actually working and it's actually happening, but it's a process. The goal was to have around 280 community mental health centers implemented by 2021, which was very ambitious, but it was a reasonable goal based on the mental health care needs of the country. But at this point, we are not going to get there by 2021, but we are getting close to that. And I think we are changing the way mental health care is delivered in Peru. The number of psychiatrists in the whole country is about 700 to 800 psychiatrists. 800 psychiatrists, I would say between 75 and 80% are in Lima, meaning that there are only 20% or around 150 psychiatrists that are outside Lima, despite the fact that outside Lima we have around 20 million people living. So, and that's another another limiting factor, that the mental health care workforce is very limited.
In terms of the actual practice of psychiatry in here versus Peru, are there any major differences that you've noticed in terms of diagnosis and treatment? Do you feel like it's kind of seamless practicing here to there? Is there any kind of shifts you have to make in terms of either cultural differences or resource differences or anything like that?
Yes. One of the main things that play a role when we deliver mental health care on the field over there is the culture and cultural background of the patients, because that can be, that's very different to how we practice here in the US, because the cultural background in Peru, the Peruvian population is very different, and that's something that we need to take into consideration when we see them, because a lot of times our recommendations would not be relevant if we don't take that into consideration. Sometimes patients over there do not believe in psychiatry. Sometimes they have their own cultural beliefs and interpretation of mental health symptoms, of anxiety, of depressive symptoms, and we need to understand their belief system first before we're able to even propose an intervention. And that's why sometimes over there sometimes it's difficult to start a medication because sometimes there is a lot of resistance. The other thing is we really rely on the clinical assessment because we don't have access to expensive lab work or expensive imaging or anything like that. So we really need to rely on clinical judgment and clinical signs. The other thing is the medications that we have over there. On some places there may be only 1 or 2 antidepressants, 1 antipsychotic, and 1 benzodiazepine or something like that. So it's very limited, the amount of medications that we have available. But you see that most of the times those are the main medications that you would need to treat 80% or 70% of the population of the patients with mental illness. Here to order like an MRI or CT for a patient with a first break psychosis would be only 1 click, and that would be it, and you would have the CT on the system in a day or so. Over there, other places outside the US, you have to be very mindful on what you order because it's not available, one, and if it's available, the patient would need to spend a lot of resources to get it. So you need to think about the cost-benefit analysis of each intervention that you propose, especially when treating a patient with a mental health condition.
Thank you so much. Our last question before we wrap up, we have some residents and med students that are listening as well. How have residents and or med students or others gotten involved, and what other advice would you have?
Medical students and residents could get involved on trying to work with faculty members that have been actively working on outside the US or have strong connections with schools of medicine outside the US. Initiatives related to research would be very beneficial for medical students and trainees, and also initiatives related to clinical opportunities.
Thank you so much for your time. I'd like to thank you, Eric, for helping me edit this episode. I also want to mention our latest quarterly AJP Residence Journal issue that came out 3 days ago, with some interesting topics including brief historical accounts of ECT, mental health portrayed in horror movies, and more. This is Drs. Barrington Hwang, Eric Zabriskie, and Jose Alberto Arriola Vigo with the American Journal of Psychiatry Residence Journal podcast. Thanks for listening.